Welcome to Health Literacy Out Loud. I'm Helen Osborne, President of Health Literacy Consulting, founder of Health Literacy Month, and author of the book Health Literacy from A to Z. I also produce and host this Health Literacy Out Loud podcast series that focuses on many aspects of health communication, patient education, and health literacy. Today's episode is a re-airing of an important podcast first posted in 2009. It is my conversation with the husband and wife team of Cecelia, or Cici, and Leonard, Len Doak. The field of health literacy as we know it today builds on the strong foundation of research, practice, and advocacies that began with the Doaks. Well, both of them have since passed on. It is well worthwhile to listen as Cici and Len share why health literacy mattered decades ago and why it remains so important today. Today, I'm talking with Cecelia, or Cici, and Leonard, or Len Doak, a husband and wife team who I consider the founders or grandparents of health literacy. Their book, their workshops, articles, and all-around wisdom and support has inspired many of us, myself included, to improve health understanding. Cici started as a commissioned officer in the U.S. Public Health Service. During her more than 20 years there, Cici developed and led numerous health education programs. In fact, she received a commendation for this work from the Surgeon General for her work educating the public about cancer. Len comes to health literacy via adult education, and he was a volunteer for many years tutoring non-readers in how to read. Len's first career was as a Navy engineer, and among his many accomplishments, he helped simplify instructions for crews working on ships and submarines. Together, Len and Cici co-authored the award-winning book, Teaching Patients with Low Literacy Skills, that is now available for free from Harvard University's School of Public Health website. Len and Cici work together in their not-for-profit business, Patient Learning Associates, Inc. Together, they have written guidelines for numerous important projects and analyzed the suitability of more than 2,000 healthcare materials in virtually all formats. They have presented at more than 200 health literacy workshops across the country and around the world and have trained over 11,000 professionals of all disciplines. Talk about making a difference. Wow. Personally and professionally, Cici and Len are my heroes. Thank you for talking with us and welcome to Health Literacy Out Loud.
Hi, it's tough to be a hero.
You are my heroes. I love seeing you whenever we meet at conferences all across the country. To me, the two of you are the trendsetters, the groundbreakers, the people who got health literacy started. Do tell, how did all this begin?
Well, I guess the best way to say it is that our work in health literacy started with our marriage in 1973.
Okay, make that clear for us.
Well, I was in continuing education for physicians and allied health personnel, way at the other end of the continuum from literacy. And so when I met Len, and he told me he was volunteer tutoring people who couldn't read and write, I said, my heavens, how do people with low literacy skills understand medical advice? What happens when they go to the doctor? And then Len answered.
I said, hey, often they don't understand, and they may pretend to understand, to avoid embarrassment. And, of course, that helped fuel the belief of many docs and nurses that, hey, we don't have any of those low-literate people in our practice.
That's where we started. I think the thing that's important here is that people who don't read well are not lacking in intelligence. And as Roger Shai pointed out, who is a reading specialist, said people in general make judgments about other people by the way they talk. And if they speak in broken phrases, say, I done took what you told me to, or damn and does, we sort of click in our mind that this person isn't very bright. And what we started out in doing is to separate out some of the misunderstandings and misconceptions about literacy. that people are not dumb. It's a matter of skill.
Helen, could I tell you a little story to illustrate that?
Sure. Tell us, how did this got started? Yeah.
It's fairly short. My first student was a man named Alan. He was 26 and was married and had children, and he had a good job as a machinist in a small town in upstate New York. He couldn't read or write. He didn't even know the letters in the alphabet. He could sign his piecework as a machinist because somebody had taught him by rote how to write his name. He practiced it 100 times. And you could learn to write your name in Arabic backwards if you practiced it 100 times. So I asked him, how do you get by at work? Don't you have to read blueprints? And Alan says, yeah, but we don't get them too often. So I said, what do you do when you get them? He says, well, I steal the print and take it home. My wife reads it to me, all the dimensions, all the materials, all the lubrications, all of the tolerances, and so forth. And then I memorize that, and then I go back to the plant and make it.
Wow.
Now, is this man lacking intelligence?
Sure doesn't sound that way.
It was one of the first things when we started workshops and working with health professionals is to clarify this point. What we're talking about is building a skill and helping health professionals work around the problem of literacy. We're not trying to solve the problem, we're trying to manage it and to work around literacy issues so that people can more readily understand. That means simplifying instruction.
That's an important point, and I like the way you frame it, that it's trying to manage it or work around, not introduce those literacy skills. I know as a health provider myself that we don't have time when we're in the middle of a clinical encounter to be dealing with that. It's just, how can we be working with that?
That's right, Helen. But it's also, the reading field is made up of people who have spent their careers in learning the skills of teaching people to read. We don't want to do that. We want to work around the problem so that the patient walks out of the office knowing what to do and how to do it. And I think that the definition of health literacy, which came out in the Department of Health and Human Services Bulletin for Objectives for 2010, they talk about the definition is the degree to which individuals have the capacity to obtain and process and understand basic health information. So it's not just a matter of reading, but it's also understanding and being able to process the information.
Well, thank you for that. Can I take some steps back with you, please?
Sure.
So now it's 30-some years ago. You were working with Alan. You two were newly married. You're realizing that not everybody understands health information. It's quite a leap from there to what you just told me about a definition that's in Healthy People 2010. Tremendous amount of work has happened at that time from your very first awareness. How did health literacy get started as a field or a discipline for study that people are really paying attention to? What happened in those early years?
One of the things that happened is that when we first started doing workshops, people were terribly hungry for a solution because the docs and nurses and dietitians and nutritionists and others who were on the firing line, were in contact with patients. They realized that the patients didn't understand, but they were trained formally and, using college-level words. They didn't know how to cope with this, how to manage this, how to make their message understandable and motivating to people.
I think one of the things that we did first, Helen, was we looked at the literature on health education and literacy, and we found that there were only 3 professional papers written before 1979
Really?
On health literacy. And then Dr. Pat Lawrence in the University of North Carolina did a research project on how many pamphlets or materials are available in diabetes in health literacy. This is 1979. And she found that there were only 12 publications with a reading level of grade 7 or below. And 10 of those were on single concept sheets that really didn't stress very much about the behavior of the patients. If there's one characteristic that we noted as we reviewed health instructions back in the early days was that the instructions followed the medical model of epidemiology, talking about the disease process, what happens as far as the body is concerned, and so on. And then at the very end, getting to the behavior. And what we stressed in literacy was just the opposite. Start with the behavior. Don't worry about whether or not they understand the disease process. The thing to worry about is, do they understand what to do when they go home?
You now have this new awareness. You see that there's a problem. There's scant little research out there. What happened next? How did this go from just an occasional person interested in this topic to really becoming a movement and a discipline in its own right?
It happened rather gradually and over a period of years, frankly, Helen. One of the things we did was to test the reading and comprehension skills of 100 patients at a public health service hospital. And then we tested the readability level of the materials these patients were given and told to follow. And we found there was a big gap that the patients on average read at 7th grade. The materials averaged at the 12th grade, a 5-grade level gap.
Huge.
So we published that, and that began to catch attention.
Aha.
We did work for the Division of Hospitals for the Public Health Service. This was back in the days when the Public Health Service still had hospitals. The clinical directors were just shocked, and we were invited to present papers at their clinical sessions, not just their educational sessions, the typical education sessions. And it was when we got into the clinical world that things really began to happen.
So you started with some workshops and some papers and actually assessing some materials.
Right.
Tell us what happened next.
One of the things that we did is to make it more meaningful for the participants in our workshops. We asked in advance, and we invited them to send us some of the materials in any mode of communication that they were using and found troubling or that they were developing. And we would give them feedback on it as to the strong points and the weak points. So we began to develop a sense of what works, what doesn't. We tested some materials that were sent in to us and decided that we would like to evaluate those with patients. And these were patients on dialysis.
Kidney dialysis.
Kidney dialysis. So we visited a kidney dialysis clinic and had arranged their permission to talk with patients about material. And one of the materials we wanted to test was diet, because if you're on dialysis, you have to watch your diet. And the story is that on dialysis, you should eat red meat, and the instruction said you should avoid shellfish and poultry. Okay? So I asked this gentleman, I said, Fred, would you read this for me? So he read it. And I said, what's it all about? He says, it's about what you're supposed to eat.
That's good.
So I said, okay, what do you eat for dinner? And he says, well, I have sometimes chops or steak, but fried chicken is what I eat most of. And I said to him, well, Fred, but what about poultry? Well, you never eat poultry. We're not allowed to have that. Poultry is a category word. Do you ever see poultry listed in the supermarket? No.
Yeah,
they don't sell poultry. They sell chicken or turkey or something.
Oh, so that's an example of a category word. So when we in healthcare are communicating in that ways, our messages are just gone.
They're gone.
They're not nearly as effective as we're pretending that they are. Along the way, when I first heard about health literacy, my awakening was in 1995. I was working at a community-based hospital in one of the poorest parts of Boston at that point. I read an article that was in the Journal of the American Medical Association about health literacy and how many people have trouble understanding. And I looked around at my population and I just clunked myself on the head and said, yep, these are the folks I'm working with. And at that point, I don't need to replicate the research. I just think, okay, there's a problem. I get it. What can I do about it? And at that point, there was that one article, and I found exactly one book written by Doak, en route, your book. And I found that the underpinnings, the Bible, the fundamental for all the work that I did for many years thereafter, your book is just a tremendous resource.
Thank you.
So can you tell us a little bit more about that book?
It started, of course, from the workshops, where many of the people in the workshops asked, isn't there a book I can read about all this? And we had people who had just gotten their Master of Public Health in Education and said they never even mentioned readability issues to me. I never heard of those things before. And so after hearing that a number of times, we decided that we would try to put together, based on our workshops, a book that would be a reasonable, practical resource.
Your book is just a wealth of how-to strategies, and I just want to tell listeners hearing this that your book, Teaching Patients with Low Literacy Skills, the second edition, is available for free online through the Harvard University School of Public Health website. We will have a link on the Health Literacy Out Loud website of that resource as well as others that you mentioned. So thank you for that. You have something in there that I often use and refer to as almost the gold standard of materials, and that's your SAM, your Suitability of Assessment of Materials. Could you talk about that a little bit, please? Not only do we do the right thing, but how do we know we're doing the right thing?
We always had some kind of strategy, but it wasn't until we were doing a study for Johns Hopkins University on nutrition materials and the suitability. They had a selection of 75 materials, and they wanted to know which ones are really suitable for patients across the board, including patients with limited literacy skills. So we relooked at our research and the practice and came up with a set of criteria that you could measure numerically for each piece of material. Ceci, would you like to expand on that, please?
I'd like to just expand on the research that we did. The Women, Infant, Children program had a very good checklist on materials that they were using, but it was limited mostly to the reading level. At that time, visuals are very seldom considered material for examining or analyzing for low literacy, and yet visuals are the first thing that people with low literacy skills look at. So we decided to benefit from the checklists that were already available, but expand them to include the points that we felt for low literacy are critically important, and that includes culture.
One of the things that's happened is that's just one of the first comprehensive and quantitative measures of suitability of materials, and today it is being used routinely at many medical centers throughout the United States.
So I'm hearing lots of strategies from you about concepts and categories and context and value judgments, and pay attention to that. What would you see in a perfect world? If this was a health literacy perfect world, what would we all be doing?
One would be for health literacy to be integrated and made a part of the education of doctors and nurses and other healthcare professionals. That way, it would be an ongoing thing, and you wouldn't have to episodically do training and workshops.
I think that in the health literacy field, we need to be aware of that we need rewards. I mean, institutions need rewards. The healthcare professionals need rewards that their work is producing something. And I think accreditation agencies, like a number of the big medical care institutions like Kaiser Permanente and so on, have included literacy in their criteria for accreditation. And I think that is also an important step, so that people in the institutional field know that by trying to meet literacy standards, they are also helping their own institution achieve accreditation standards.
I'm hearing from both of you that in this perfect health literacy world, it takes the efforts of many. It takes the day-to-day professionals to do what they need to do and use the pictures, use the simple words, put all our information into context, into a person's life. But it also takes the accreditation agencies. It also takes the literacy specialists we can learn from. It really takes, as you two did in your life, it takes a marriage of all of us to make healthcare more understandable.
That's very well stated.
Thank you so much for sharing your historic perspective, your views, your visions. You're terrific.
Oh, thank you. So are you, Helen.
So are you, Helen. You're the one, the new Pathfinder.
As we just heard in this re-airing of a conversation with Len and Ceci Doak, it is important to communicate about health in ways that patients and the public can understand. That's what health literacy is all about. But this can be hard to do. For help clearly communicating your health message, please take a look at my book, Health Literacy from A to Z. Feel free to also explore my website, healthliteracy.com, or contact me directly at helen@healthliteracy.com. New Health Literacy Out Loud episodes come out the first of every month. You can get them all for free by subscribing at healthliteracyoutloud.com or wherever you get your podcasts. Please help spread the word about health literacy out loud. Together, let's tell the whole world why health literacy matters. Until next time, I'm Helen Osborne.